The last speaker is Shilpi. Dr. Shilpi NARNAWARE will be talking to us about post-procedure red eye. And then we'll have some questions.
So good evening everyone. Thank you VOS, AIOS and APO for this opportunity. So I will be speaking on post-operative red eye. So any exaggerated inflammation after any procedure is always a nightmare for any surgeon. So first we have to look at the scenarios after the surgery. It can happen whether it is because of the surgical trauma in an eye which is predisposed, in sometimes in traumatic surgeries and cluster or single cases. So surgical trauma, other day you will see, yes, it depends upon the duration of the surgery, prolonged phaco time, iris chafing, posterior capsular tear, big pupils. These are the signs that you had surgical trauma during the surgery. While there are few predisposed eyes which will present later as exaggerated inflammation post surgery. Especially in diabetic patients, we see that up to 20% of all the cataract procedures are for the diabetic patients, and we get severe fibrinous reaction in 10% of these patients. 21% cases of these are of established endophthalmitis, which are culture positive in 79% and gram negative in 18.5% of the cases. While the major concern is inflammation in a traumatic surgery. It can be non-infectious or infectious. So this was a patient who was 25 years old male who presented with history of trauma 10 years back. There was epithelialized interior capsular rupture. Intra-op, it was uneventful surgery, but post-op, he presented with AC cells of 2+, fundus, there was a hazy view. B-scan was done, which showed minimal opacities on the high gain, and he was managed with topical steroids and cycloplegics, and a day later, this was the picture. So this was a case of anterior chamber associated immune deviation, which is actually an immune protection to the eye and which interferes minimally with the vision. It avoids a harmful immune response to unique molecules which immune system never regards as self. We need to differentiate between TAS and endophthalmitis. TAS is a sterile post-op inflammation which happens because of the toxic damage due to the non-infectious substances which enters the anterior segment. It can happen as an isolated case or even in cluster. Clinical features are poor vision, hypopyon you may also get, fibrin or corneal edema. It can be confused with endophthalmitis, but differentiation is necessary as for TAS, steroids is the drug of choice, while for endophthalmitis, antibiotics are to be used. The major distinguishing features are that TAS is usually early onset. You will get limbus to limbus corneal edema. You will have some signs of iris damage. Usually the IOP is high and there is absence of vitritis on indirect ophthalmoscopy. But never ever, you should not ignore TAS also because it has its own sight-threatening complications like permanent corneal decompensation, intractable glaucoma and cystoid macular edema. Now, how to evaluate a case of inflammation? Always look at the history. Never ever ignore such history in any patient. If we go by the EVS study and the ESRS study, these are the clinical presentation. Red eye was never ever studied in ESCRS, but in EVS study, 82% of the patients, they presented with post-operative exaggerated red eye. So these are the various points where clinical examination we should always do. Visual acuity is important and must, not only because of from the medico-legal point of view, but because of the two major landmark studies. According to the ESCRS, visual acuity was never a criteria for taking the patient for vitrectomy. We have to check the adnexal evaluation like NLD evaluation, tear meniscus and also the conjunctiva. Slit lamp examination sometimes help us in giving whether the surgery was traumatic or not. There is any sutural infiltration or a leak. Corneal assessment is to be done for prognosis purpose also. Anterior chamber cell grading is to be done according to the Sun grading system. Iris and pupillary reactions are important, but it may be masked because of the cycloplegics or because of the exudates. Positioning of the IOL helps you in determining whether the surgery was traumatic or not. IOP should always be done, and it should be always a sterile IOP by the applanation tonometry. Usually IOP is low in cases of endophthalmitis except when it is UGH, TAS or fungal endophthalmitis. Posterior SIGBIT evaluation is done on slit lamp biomicroscopy and also with the indirect ophthalmoscopy depending upon the grading given by the Sun working group. B-scan is equally important as it shows the density of the vitreous opacities, whether vitreous membranes are present or not, presence of nucleus fragments or IOLs, choroidal detachment and chorioscleral involvement. So these are the various B scans which we should look for the various opacities, choroidal detachment, inflammation of the ocular coats. So how to manage? If you are not sure whether it is a TAS or endophthalmitis, never ever start with the oral steroids or no AC wash in such cases. Increase the frequency of the topical steroids and re-evaluate the patient after 4 to 6 hours. If still in doubt, treat it as an infective case and always treat it as a case of endophthalmitis. Microbiological investigations are important even if you are managing a patient medically. Either the aqueous tap or the vitreous tap, it has to be given. The isolation rate of vitreous tap is more compared to the aqueous tap. PCR has the more isolation rate. With the aqueous sample it is 84% and with the vitreous sample it is 92%. But remember, negative cultures does not rule out inflammation. Negative cultures can be seen in presence of the fastigious organisms, insufficient sampling or sterile endophthalmitis. If you still suspect that it is a case of endophthalmitis, always send a repeat culture. Vitrectomy, if has to be done, it should be diagnostic and therapeutic. Principle is to debulk as much as you can. So these are the few cases which I will share. It was a case of non-diabetic 73-year-old gentleman. He has a dark, hard brown cataract, uneventful surgery, and was advised subconjunctival antibiotics and oral steroids for inflammation at day 1. So this was the presenting picture on day 1. On slit lamp examination on the retroillumination, there was good glow and the vitreous was clear on indirect ophthalmoscopy. So diagnosis of traumatic uveitis or TAS was made. The treatment given was increase the frequency of the topical steroids and cycloplegics and stop oral steroids. 6 hours later, there was improvement in the AC reaction. So hypopyon does not necessarily mean infection. Retroillumination and indirect ophthalmoscopy ruled out the vitreous involvement, so that's why the diagnosis of TAS was made. This was another case. He was a gentleman post vitrectomy with grade 3 nuclear cataract and had uneventful cataract surgery. On day 1, there was streak hypopyon, mild reaction, while on the B scan on 90 decibels gain, there was minimal opacities. So these are basically the residual silicone oil opacities in this patient. This patient was also treated with topical steroids and cycloplegics, and on follow-ups at 6 hours later, there was reducing inflammation, and at 24 hours, it was almost near normal. So post-vitrectomy eyes reacts more severely, and so also the young patients. This is another case, status post PRP and anti-VEGF. And at day 1, this was the picture. Trial of topical steroids and cycloplegics was given, and at day 2, this was the picture. So any patient who has underwent vitrectomy, anti-VEGFs or any retinal treatment, they are more prone to severe reaction post-operatively. Not necessarily it can be a endophthalmitis. This is the another case who had traumatic surgery and had asteroid hyalosis preoperative. So day 1, this was the picture. B scan was done elsewhere at 70 decibels and it was interpreted as asteroid hyalosis. Patient was started on oral steroids and 3 hours later this was the picture. And when the B scan was done at 90 decibels, there were severe vitreous opacities. Diagnosis of acute endophthalmitis was made and patient was undertaken for the vitrectomy. In this case, this patient was diabetic under treatment and was given oral steroids for inflammation after the surgery. If you get this type of a picture, there is no role of oral steroids in such kind of a picture. So always take the patient for vitrectomy. Now, this is the last case, a non-diabetic pseudophakic patient who received anti-VEGF biosimilar for CNVM. This was the presenting picture at the referring surgeon at 6 hours. There was a hypopion, minimal reaction. The doctor thought it is a sterile inflammation and the topical steroids and cycloplegics were given. But 12 hours later, there was membrane hypopion increase and the patient was posted for vitrectomy and intravitreal antibiotics. So to summarize, any exaggerated post-op inflammation is real-time emergency. We should always do a thorough clinical examination. B scan should always be done at 90 decibels. If you are suspecting it's a TAS, you should treat it with intensive topical steroids and cycloplegics. If in doubt, always take a vitreous sample and try to do vitrectomy as much as possible and treat it with intravitreal antibiotics. Post anti-VEGF, it's very less likely that it will be a TAS or any other inflammation. Always treat the post anti-VEGF patients as endophthalmitis and take them for vitrectomy as soon as possible. Thank you.
Thank you so much. This is the last topic. And any questions now? Because we do have 5-10 minutes.
We always are in a denial mode when it comes to endophthalmitis. So I think one has to keep in mind the post-op loss of glow and all could be because of endophthalmitis. Most of us would like to believe that it is TAS. So that one thing delays the treatment sometimes.
You nailed it, ma'am. Basically, it's most of the times when we get as a vitreoretinal surgeons, the patients at a late stage, it is a denial mode. अरे सब अच्छा हुआ था, let me give trial of steroid देता हूँ, ये देता हूँ. Please don't do that. The moment you see inflammation which is more than acceptable for that type of surgery, traumatic surgery or a traumatic surgery you did, it is prudent to think it as an infective. A shot of intravitreal antibiotic is not going to harm as much as a shot of a oral steroid or an oral tablet of 10 milligram, 20 milligram which you are giving.